Everyone, and welcome to today's session. My name is Erin. I use she, her pronouns, and I'm a learning officer here at EGAL. Today, I am putting on my moderator hat, so you won't be seeing too much of me, but I am here to get us situated before we get started. So the first thing that you will have noticed is that we are recording today's session. This is for internal quality assurance purposes, and I believe this recording will also eventually end up on our YouTube. I'll double check with Brittany later, but you will receive more information about that if you're interested. There will be a few features to pay attention to today. There should be a ribbon at the top or bottom of your page. If you can't see it, it might just be set to be minimized. So if you swipe your finger or mouse across the page, it will pop up. There are three things to pay attention to. First is the chat pod. We already have some wonderful people introducing themselves there. This is where you can ask questions, make comments, share resources. We'll also be sharing our research in there as well. There'll be a survey in there at the end. Don't worry if you aren't able to grab these things in the moment. There will be a follow-up email in 24 hours that will have everything that we have shared. The next thing to pay attention to is the Q&A pod. This is another place where you can ask questions. These come directly to us, so no one else in the audience will be able to see it. And if you, for any reason, want to be anonymous, you can also click in there that we aren't able to see who you are either. If we respond to any of your questions, we'll do our best not to call you out by name, just so we have a little bit more anonymity and everyone can be comfortable. The last button to pay attention to there as well is the captions or CC button. This only affects your screen, so feel free to turn it on or off as you feel comfortable. And this session benefits immensely from your participation, so we encourage you to use all these features to ask questions, share resources, and stay engaged. And the last thing I will go over before I pass it over to Brittany is who we are, in case you have never heard of EGAL before. So for those of you who don't know us, EGAL is Canada's leading organization for 2SLGBTQI people and issues. We improve and save lives through research, education, awareness, and by advocating for human rights and equality in Canada and around the world. Our work helps create societies and systems that reflect the universal truth that all persons are equal. And with that being said, I will pass it over to Brittany.
Thank you, Erin, and hello, everyone. My name is Brittany Jakubiak, and I am the Director of Research at EGAL Canada. I'm so happy to welcome you all to our second Research Highlights webinar. We've got two more this year, and I'll share the link in the chat to check that out. Today, our guest speaker is Jay Tung, who will be speaking to us about the perspectives of 2S LGBTQ plus people in Atlantic Canada around the topic of medical assistance in dying for mental illness. Jay is a PhD student at the University of Victoria, whose research focuses on medical assistance in dying, suicide, 2S LGBTQ plus health, and disability. And without further ado, I'll pass it over to Jay to lead us through the presentation.
Lovely. Thank you, everyone. And hello, as you've heard, my name is Jay. I use they, them pronouns, and I will be chatting today about my research project looking at queer perspectives on medical assistance in dying for mental illness. To start, I'll just quickly acknowledge the land that I'm on. I am currently located on the unceded territory of the Lekwungen-speaking peoples, the Songhees and the Esquimalt, and the Wasanich peoples, which is colonially known as Victoria, BC. I also want to acknowledge that by its nature, this project both upholds and is confined by colonial provincial borders that do not reflect the relationships that Indigenous nations have with the land. The region known as Atlantic Canada is located on the unceded territories and homelands of the Mi'kmaq, Wolastoqey, Beothuk, Innu, and Inuit. In this project and in this presentation, I talk a lot about the impacts of oppression and marginalization, and it's important to acknowledge and foreground the fact that, particularly for Indigenous nations in so-called Canada, colonialism is a significant cause of much of the historic and ongoing oppression and marginalization. Also, a quick content note, this presentation is going to include discussions of suicide, mental illness, ableism, and other forms of discrimination, and medical assistance in dying. So please take care of yourselves. Feel free to leave, mute, or disengage in whatever way is needed at any time. A little bit about me. I am a queer, trans, disabled, second generation immigrant and a settler. My mom is a white settler and my dad was a refugee from Vietnam. I grew up as an uninvited guest in Mi'kma'ki. Specifically, I grew up in Epiquid, colonially known as Prince Edward Island. And for 4 years, I lived in Chibukta, colonially known as Halifax, Nova Scotia. I am autistic, so I appreciate in advance your understanding of any fidgeting or lack of eye contact. I also have a bird. She is a dove and her name is Chicken. She is napping right now, but you might see her flying around in the background a little bit later. As Brittany said, I'm a PhD student in the Department of Sociology at the University of Victoria. I got my Bachelor of Science in Biology and Psychology from Mount St. Vincent University and my Master of Science in Social Dimensions of Health at UVic. And of particular note for this study, I have been suicidal for the majority of my life, which had a large influence on my interest in MAID. The study really emerged from my experiences as a suicidal, queer, racialized person in Atlantic Canada. And I'm also getting a note that my internet connection is unstable. So if I drop out or if you can't hear me, somebody please let me know. As an overview of what we'll be doing today, I will go over some information on the background of the project and then the methods and participants. Then we'll get into the bulk of it, which is the results. For this presentation, we've divided the results section into 5 broad topics. These are healthcare system readiness for implementation of MAID for mental illness, suicide MAID for mental illness and harm reduction, impact of MAID for mental illness on marginalized communities, contextualizing MAID policy, and then systemic failure and community care. And then we'll wrap it up with a brief summary and conclusion. So let's get into it. First off, you'll hear me use the term disability a decent amount in this presentation, so I always like to start by explaining what I mean when I use that term. I understand disability as a relationship to power, and I use the definition written by Sammy Shulk, who is a Black queer disabled woman and a disability scholar. And she defines disability as a term that recognizes the collective affinities among disabled, impaired, sick, ill, and mad people who are connected not by essential or inherent qualities, but by the related oppressions we experience for our non-normative body minds. So importantly for this presentation, this definition of disability can include mental illness. So mental illnesses can be classified as disabilities, but not every disability is a mental illness. Talk a little bit about MAID. Medical assistance in dying goes by a lot of different names. It's also referred to as physician-assisted death, voluntary euthanasia, medically assisted death, and assisted suicide. And it is a process that allows someone who is found eligible to be able to receive assistance from a medical practitioner in ending their life. Because my research is located in so-called Canada, I'll be using the terminology that is used here, which is medical assistance in dying or MAID. So Canada currently has the highest MAID rates in the world. From 2016 to 2023, over 60,000 people in Canada have died by MAID. And in 2023, MAID accounted for nearly 5% of all of the deaths in the country. MAID was first legalized in Canada for physical terminal illnesses in 2016. And at this time, there was a requirement that the person's natural death had to be reasonably foreseeable in order for them to be eligible. And this means that MAID was essentially available only to people with terminal illnesses. And then in 2021, Bill C-7 was passed, which removed the reasonably foreseeable death requirement and legalized Track 2 MAID, which is for physical non-terminal illness. Bill C-7 also included a clause that would legalize MAID for mental illness 2 years later. This was meant to occur in 2023. It was postponed until 2024 and then was postponed another 3 years. So at the moment, MAID for mental illness is set to be legalized in March of 2027. Additionally, a few weeks ago, the United Nations Committee for the Rights of Persons with Disabilities called for Canada to repeal the legalization of Track 2 MAID for non-terminal illness and emphasize the increasing number of women and marginalized people with disabilities who are killed by MAID. So gaining access to MAID in all of its iterations is often presented as a victory for disability rights. Discussions around MAID are largely dominated by talk of dying with dignity and having the freedom to choose and escaping intolerable suffering. However, there's often a lack of critical discussion about what exactly is causing this intolerable suffering. We know that disabled people are more likely to be living in poverty. We know how hard it is to access quality, culturally competent healthcare. We know that disabled people are often institutionalized against their will and removed from their communities. And we know that all of these things are even more applicable for disabled people who are multiply marginalized. In the context of the 2S LGBTQ plus community, there's a lot that can be said generally about the intersection of queerness and transness with disability, but when we're thinking specifically about mental illness, queer folks experience higher rates of mental illness and stress due to intersecting impacts of transphobia, homophobia, ableism, racism, etc., as well as high rates of poverty, homelessness, suicide, and suicide attempts. Further, queer people experience many barriers to accessing healthcare, including mental health care and gender-affirming care, and experience prevalent anti-2S LGBTQ plus discrimination in healthcare settings, which can directly negatively impact health outcomes as well as willingness and ability to seek care. So, in discussing something like MAID, which is managed and administered by the healthcare system, it is important to consider the power dynamics that are already present in that system. And it is also important to consider differences in healthcare within and between provinces. I like to contextualize why I chose to locate this project in so-called Atlantic Canada, which includes the provinces of Newfoundland and Labrador, Prince Edward Island, Nova Scotia, and New Brunswick. And it is largely due to my own connections to the community there, as well as the lack of research in the region. But it is also because the healthcare system in Atlantic Canada is, in the words of my participants, overburdened, a nightmare, abysmal, actively collapsing, and falling apart at the seams. They said that family doctors feel like a myth. The only emergency room in the province closes between midnight and 8, and you just kill yourself then, I guess. The entire healthcare system is falling down around us, and it is where healthcare goes to die. And there is an overarching sentiment that it's easy for the rest of Canada to say that we don't matter, we don't exist, and we don't need help. So, in essence, we cannot have a critical conversation about MAID if we are not using an intersectional lens. In 2020, Sammy Shalk and Gina B. Kim developed a feminist of color disability framework, and this emphasizes the relationships between ableism, heteropatriarchy, white supremacy, and capitalist violence. Some of the key considerations in this framework examine who society labels as disabled or deviant and why, how systems are set up to create and maintain disability in certain populations, and how disabled lives are consistently framed as disposable. And using this framework, we can begin to challenge traditional framings of MAID as a universal positive and begin to ask if we are providing accessible pathways to death without providing equally accessible pathways to living and thriving. And if so, who is being most affected by this? Moving on to our methods. So the project that I am discussing today was a qualitative study exploring perspectives on MAID for mental illness from 2S LGBTQ plus individuals in Atlantic Canada. And I use a interpretive description methodology informed by community engagement and the Feminist of Color Disability Framework. Interpretive description is a methodology that was developed in the field of nursing, and it prioritizes the co-creation of knowledge between participants and researchers, along with goals for practical rather than purely theoretical implications. I worked with a community advisory board that was composed of 5 2S LGBTQ plus people in Atlantic Canada who either lived with mental illness and or were mental health professionals. I met with my community advisors several times throughout the project, and they gave a lot of insight and feedback on every part of the research, from the research design to the interview guide to the design and implementation of safeguards. Because this can be a sensitive topic and can bring up a lot of difficult emotions and memories for people. We really wanted to prioritize our participants' autonomy and safety for the entire time that they were engaging with the project. So a couple of the safeguards that we had in place, all participants had access to the interview guide beforehand, and they were encouraged to let me know if there were any topics or questions that they wanted to avoid. They were able to give us contact information for a support person that we could get in touch with in case they needed some extra support during or after the interview. And all participants also had the opportunity to book a free debrief session with a 2S LGBTQ plus counselor, either immediately following the interview or up to 2 weeks afterwards. And for our methods, we use semi-structured qualitative interviews, and for data analysis, use reflexive thematic analysis. I won't get too much into that right now, but I'm happy to answer questions on that later if that's of interest. For our participants, we had 38 participants who were all 2S LGBTQ plus people in Atlantic Canada who self-identified as living with mood disorders. We chose to focus on mood disorders because in the Netherlands and Belgium, where Made for Mental Illness is legal, it's people with mood disorders who make up the majority of the population who are accessing that. Our ages ranged from 19 to 63 years old, which with the majority of our participants in the 19 to 30 age range. The majority identified as queer, usually alongside another sexual orientation, and her most commonly reported mood disorder was depression. Nova Scotia ended up being our most highly represented Atlantic province. Less than a quarter of participants identified as cisgender, so we had really great trans representation. And we had 24 white participants and 14 participants who represented diverse races and ethnicities, including Indigenous, Black, East or Southeast Asian, Latinx, and South Asian. As I mentioned earlier, we divided our results into 5 broad topics, which I'll go through more in depth momentarily. For each of these topics, I will share a couple of example questions from our interviews, a few notable quotes, and then a brief summary of key points. You will see that each of the quotes is attributed to either a participant number or a pseudonym, depending on whichever the participant preferred, as well as descriptors of the participants choosing, meaning that some of the quotes, some of the participant numbers don't have any descriptors. So we will start off with healthcare system readiness for the implementation of Made for Mental Illness. For this section, we drew from a couple of different questions, including as a person with a mental illness, did you access or try to access any professional mental health supports in Atlantic Canada, and what was your experience like? Do you have any concerns about how people in Atlantic Canada will be impacted by the legalization of Made for Mental Illness? And do you think there are any factors unique to Atlantic Canada that will make people in Atlantic Canada more or less likely to access Made for Mental Illness? So many participants felt that the MAID legislation had been created based on an assumption that access to care is equal within and between provinces. As said by participant 25, who identified as a lesbian, I just really feel like there's this disconnect where the people who are making this legislation cannot conceive of the barriers to treatment. Go live in rural Nova Scotia for a year and then come back and write the MAID legislation. And this was something that was particularly emphasized by participants who had lived outside of Atlantic Canada and who had experienced healthcare systems in different provinces. And echoing these concerns about access to care, participant 16, who is neurodivergent and Two-Spirit Indigenous, said, my fear is that the people in my communities will not be forced, but will find it easier to access MAID than it is to access treatment. Do you consider someone has exhausted all of their treatments when they've tried a few things and are now on a wait list for 2 years? A lot of participants talked about very long wait lists or things like treatment options not being offered at all in Atlantic Canada. And they discussed how things as basic as primary care are hard enough to access in Atlantic Canada, let alone any specialized services. And all of these availability issues are compounded by those who already face health disparities, such as people living rurally, people with complex or chronic conditions, and racialized or queer folks, or anyone else who requires culturally competent care. Gender dysphoria and the inaccessibility of gender-affirming care were brought up by many participants as significant points of concern. As Riley here says, who is queer and transmasculine, my big fear around Made for Mental Illness in the trans community is that people who are too unstable to access gender-affirming care might disproportionately access Made or at least try to. And I think the answer there is making gender-affirming care more accessible and not necessarily anything to do with Made. But that is a big fear that I have, that the difficulty of accessing gender-affirming care in Atlantic Canada will lead to people choosing Made as an option. A lot of our participants had struggled themselves or had seen other people struggle to access gender-affirming care in Atlantic Canada in a timely and trauma-informed manner. And participants also discussed the fact that folks in Prince Edward Island and Newfoundland specifically often have to travel to other provinces for gender-affirming surgeries, which obviously creates a lot of barriers, financially, travel, needing to take a support person, needing to take time off work. And this also draws attention to the fact that even if MAID is difficult to access in Atlantic Canada, it will unfortunately always be more affordable to travel to access MAID than it would be to travel for a surgery, because as one of our participants said, traveling to access MAID is a one-way ticket. And participant 29 summed up all of these concerns well, saying, I think that MAID implies that people have a choice. And like, yeah, you have a choice if you're rich. You can go into inpatient, you can go into different little rehab treatment homes. We don't have very many of those in Nova Scotia. And when you're not rich, you depend on the public healthcare system. And if the options the public healthcare system are offering you is be traumatized by a psych ward or go get MAID, you don't have a lot of fantastic options. To summarize, participants really complicated the idea of choice or of what it means to freely choose something in a system where few options are readily available. Difficulty accessing gender-affirming care and effective mental health care were particularly emphasized, and participants felt that policymakers had not adequately considered unequal access to care, both interprovincially regarding Atlantic Canada versus the rest of the country, and within province, referring to urban versus rural settings. Next, we'll talk a little bit about suicide, MAID for mental illness, and harm reduction. To contextualize this topic a little bit, there are a lot of discussions about the relationship between suicide and MAID, whether these are entirely separate things, whether they are similar things, and whether there can be an equitable balance of providing suicide prevention services alongside offering MAID. Some of the narratives from the government suggest that psychiatrists will be able to accurately determine whether someone requesting MAID is suicidal or not. Others argue that MAID is a form of suicide prevention. Some say that MAID is just suicide itself. So we wanted to ask participants their thoughts on this. For our questions, we had, how do you conceptualize the relationship between suicide and MAID for mental illness? How do you feel when thinking about suicide in your communities? And how do you feel when thinking about MAID for mental illness becoming an option for the people in your communities? Participants had a lot of different views and beliefs about suicide and MAID for mental illness. And I have a bird on my head now, which reflects the complexity of this topic. Some participants felt that when you really get down to the essence of it, there is very little difference between the two, such as participant 20, who said, I don't know if you really can differentiate those things. My understanding conceptually of suicide is a permanent escape or a permanent walking away from intolerable suffering. And regardless of whether that's medically assisted or self-determined, I think the kind of ideology or the reason for going either pathway would come from the same place. And similarly, participant 10, who is queer, trans, disabled, and neurodiverse, said, I find it difficult to think they could be two simply different things. Participants also had differing opinions on the idea of MAID as harm reduction or as a quote unquote less harmful form of suicide. Participant 11, who is queer, physically disabled, and a biracial person of color, said, I think that it is a form of suicide, but like I said, it makes such a difference in the ways I talked about for the person themselves and their loved ones. So I think that it is a form of suicide, but it is a much better, more dignified form of suicide that's better for everyone involved. But this was strongly disputed by some other participants, like participant 29, who said, that's not harm reduction because it's not like, oh, this is the safer way than shoving yourself in front of a train. No, it's still death at the end of the day. Another couple of differing views here. Participant 5, who's queer, indigenous, and neurodivergent, said, I know a lot of people will be like, oh, people are dying, that's not good. But if you really think about it, it's way less harmful than suicide is. So it's a much better option for people who don't feel like they can continue than going home and just taking their own life. And then on the other hand, We had participant 26, who is queer, non-binary, and neurodivergent, who said, "It is permission. It's, we don't want to clean it up, so why don't you just do it in a hospital bed? One of the reasons why I feel like I am alive today is because I didn't want somebody to find me." And again, it's just permission, it's serving it on a silver platter. So overall, participants had conflicting views about the relationship, similarities, and differences between suicide and MAID for mental illness. Some viewed MAID for mental illness as a safer or less harmful form of suicide or as a form of suicide prevention, while others viewed MAID for mental illness as a way of enabling or facilitating suicide. And these were all complicated by the prevalence of suicidality within the 2S LGBTQ plus community, as well as the lack of non-carceral, non-coercive suicide prevention efforts. A lot of our participants discussed having very traumatic experiences with crisis prevention services such as emergency rooms or crisis lines, and had concerns about how inadequate care for suicidal people would interact with legalizing MAID for mental illness. And this also brought up questions for a lot of participants in the sense of who, quote unquote, deserves suicide prevention, and thinking about whose suicides are we putting in effort to prevent, and whose deaths are we facilitating through MAID, and how are we making those decisions. Next, we'll talk about the impact of MAID for mental illness on marginalized communities. For our questions here, we had, how do you feel when thinking about MAID becoming an option for the people in your communities? How do you think the 2S LGBTQ plus community will be impacted by the legalization of MAID for mental illness? And what about the other communities that are important to you? And how do your identities shape the way you think about MAID for mental illness? Participants generally had a lot of concerns about how the implementation of MAID for mental illness would interact with existing systems of oppression. Participant 4, who is mad and queer, said, "Any marginalized community is going to be negatively impacted by MAID in general. The people who are going to be impacted are people who have less access to other choices, who are racialized, marginalized on however many intersections. These are the people whose social workers are going to say, have you considered MAID instead of therapy?" A lot of participants recognize that much of the discourse around MAID is based around the idea that it is better to be dead than disabled. And they worried that the continued expansion of MAID would only serve to normalize this narrative and even enshrine it as policy. Carmen, who is queer, racialized, and disabled, said, "It goes back to a lot of the ableist things that I've been told of, I could never live like you. Oh my God, if I had that condition, I would just want to die. And yeah, I do. Been there. I don't need a reason to be encouraged on it. Seeing this as the solution that's being proposed is just so infuriating. I've gotten into some deep existential spirals about it even just existing. Every time there's a new development, I've gone to some pretty rough places." And this just highlights the way that even just the existence of MAID is impacting people by reinforcing the idea that their lives are not worth living. And participants were also very cognizant of the ways that the healthcare system has been used as a tool of violence and genocide, specifically against Indigenous and Black people. And they worried about MAID being weaponized in this way. Participant 22, who is two-spirit and disabled, said, "We have situations where doctors are sterilizing Indigenous women without their consent. What's stopping them from using MAID without their consent, or like forcing it down their throats without really fully understanding their options? That's my biggest fear there. I can foresee it happening." And all of these concerns were further exacerbated by the fact that this healthcare system in Atlantic Canada is so overburdened and under-resourced, and participants worried about the possibility of doctors being incentivized to promote or provide MAID specifically to ease the burden on the healthcare system. So here, participants expressed concerns about the ways that existing systems of oppression would interact with MAID for mental illness. Given the historic and continuing role of healthcare in eugenics and in colonial violence against Indigenous people, participants expressed specific concern about MAID for mental illness becoming another tool of genocide against Indigenous people, and MAID for mental illness exacerbating ableism and perpetuating narratives that disabled people are better off dead. Moving into talking a little bit about MAID policy and the context around it. Here, we were looking to ask participants, what recommendations would you provide for policymakers to create a MAID policy that prioritizes the needs of 2S LGBTQ plus people and those in your other communities, as well as what would thriving look like for you and your communities, or alternatively, what would justice look like for you and your communities? So when we asked participants about providing recommendations around MAID policy, many of them discussed the fact that we can't make an equitable MAID policy if we are not providing the things that people need in their day-to-day lives. Participant 14, who is a Black, queer, disabled femme, said, I think it is important to first address the social determinants of health and other factors that could potentially improve people's mental health care and improve people's quality of life before jumping to MAID. Because I don't think they've had a single conversation with people from these communities. Because I do think if you have conversations with people in these communities, again, they will tell you, maybe if I had access to XYZ, then I wouldn't want MAID. Similarly, participant 12, who is genderqueer and disabled, said, no one can thrive without housing security. You cannot dig yourself out of suicidal ideation if you do not have secure housing, if you do not have access to food, basic human needs. And Riley, who is queer and transmasculine, said, a lot of the recommendations I would have would be around increasing access to other services alongside MAID, like creating peer support programs that are adequately resourced to talk about suicidality and talk about the desire to die. Again, just a need for services that allow people to talk about suicidality without the threat of involuntary intervention. So again, participants emphasize that in order to create equitable MAID policy, other social determinants of health need to be addressed first, and particularly they talked about housing, food security, and access to healthcare, including gender-affirming care, mental health care, and non-carceral care for suicidality. And our last topic here, I'll talk a little bit about participants' emotional responses to the idea of legalizing MAID for mental illness in a time of systemic failure in healthcare and the ways that community care is essential to survival. Our questions here. What are current sources of strength and support for you and your communities, and how can these sources of strength and support be created, reinforced, or supported? As well as a person with a mental illness, how do you feel when thinking about MAID becoming an option for people with mental illness? So, when thinking about the idea of legalizing MAID for mental illness, participants, it brought up a lot of emotions for people, including anger, bitterness, abandonment, and betrayal, particularly for folks who had struggled for a long time to access care or to get needs met. For participant 26, who is queer, non-binary, and neurodivergent, they said, making it easier to be murdered by the government than to access gender-affirming care, safe spaces, shelter, food. I mean, it sends a very clear and obvious message. And if you think about it for more than 10 seconds, it's very clear they would rather treat us like garbage than treat us like human beings. And similarly, participant 22, who is two-spirit and disabled, said, I get pissed off because I think that this is tiptoeing, not even so much as tiptoeing as sprinting towards eugenics at this point. It feels like being dismissed as because you are suicidal, we're just going to help you along and kill you rather than talk about why you deserve to live. And in the face of all of this systemic failure and abandonment, participants found a lot of strength in their communities. Participant 32, who is queer, Black, and neurodivergent, said, I would say the communities that I've been able to build, just building stronger relationships with Black queer folks who are also gender expansive and also mad and neurodivergent, that's been the strength there, knowing that I actually am not alone in at least these ways, and that there's spaces I can go where I can be like, I actually want to kill myself, and I'm not going to be in danger for being honest. And I can talk about like how racism impacts my suicidality and not feel weird about bringing it up. And those are where my strengths are. However, even as participants stressed the importance of community care, especially in difficult times, it's also true that community care is imperfect, and sometimes oppression and lack of support from the system can create need within community that isn't sustainable. Gordon, who is queer, white, and disabled, explained this, saying, I do feel like there are so many people who can understand what I'm experiencing and people that I can reach out to. But it's also heart-wrenching in that I know how many people are experiencing this and how many people are suffering, and yet I can't be there for all of my friends that I want to be there for because I'm not even at full capacity. So the people that can help can't, people who do understand can't be there to understand because they're experiencing the same thing. So here, participants discussed their anger, bitterness, and feelings of abandonment related to the idea of legalizing MAID for mental illness in the current reality of our healthcare system and of our society at large. Many participants had turned to community care and mutual aid, which they described as life-saving. However, participants also noted that community care is not perfect, and systemic failure to meet needs often creates demand for community care that is unsustainable in our current system. So, to sum all of that up, participants experienced many barriers to accessing healthcare in Atlantic Canada, which exacerbated their concerns about MAID for mental illness being integrated into the healthcare system. They felt abandoned by the system. They understood MAID for mental illness as related to suicide in a complex way. They worried about how legalization of MAID for mental illness would impact marginalized communities already facing systemic oppression. And they emphasized the needs for improved healthcare and social supports such as housing and income. And what can we do with all of this information? First, advocate for policy on MAID for mental illness that would most align with the needs of 2S LGBTQ plus communities. Obviously, this first means that we need to understand the needs of our communities, and particularly those in our communities who have been most abandoned by the system. Similarly, advocate for opportunities for 2S LGBTQ plus people, and particularly those who are multiply marginalized, to provide input on MAID policy and implementation. Third, start safe and informed conversations within communities and organizations about MAID for mental illness and about the complexity of navigating MAID for mental illness alongside suicide prevention in 2S LGBTQ plus communities. I know that suicide prevention has been a priority for a lot of queer organizations over the past many years. And I think it's very important that we, within these organizations and among the people who are doing this work, be prepared and informed and just ready to navigate the situations that we may run into once MAID for mental illness is legalized and figure out how to best support our communities as we're going through this transition. Next, stay informed on policy development around MAID and MAID for mental illness. The media often does a very bad job covering updates on MAID, which was exemplified by the lack of media coverage of the recent UN call for Canada to repeal Track 2 MAID. However, there are a lot of advocates, academics, and organizations out there who are sharing critical and informed information about MAID policies, both here in Canada and around the world. On the same track, engage populations whose perspectives have been excluded from conversations around MAID for mental illness. We often hear a lot from MAID lobby organizations like Dying with Dignity. On the other side, we often hear a lot from religious organizations. So make sure that you're seeking out perspectives from people who aren't so often platformed. Disabled people have been talking about MAID and the dangers of MAID for disabled folks for years and years. Seek out perspectives from unhoused folks, queer folks, Indigenous people, etc., particularly for people who work in media or academia. Be very intentional about whose perspectives you're highlighting. Next, support and increase advocacy efforts for improved physical, mental, and gender-affirming healthcare for 2S LGBTQ plus communities, including non-carceral strategies for suicide prevention. As our participants discussed, there are a lot of situational factors that contribute to mental illness and suicidality, and a lot of different supports that could be put in place outside of MAID. And finally, continue to contribute to mutual aid, take care of the people in your communities, and learn how to best support each other through difficult times. Find, share, and contribute to mutual aid campaigns to the best of your ability. Mutual aid is truly what keeps a lot of people housed, fed, and alive right now. And just take care and support each other. I want to end on two quotes from participants here. The first is from participant 14, who said, "I wouldn't jump on the offer of MAID because I went for a nice walk with my friends yesterday and it was really nice. Like, I would miss the little walks, I would miss the banter, I would miss the chit chat, I would genuinely miss my community." And from participant 29, "At the end of the day, community is what is going to save your life." I will briefly go through my references here. I'm happy to go back to that slide if folks are interested. And I will end it there. Thank you all very much for coming. And as always, a huge thank you to all of the community advisors, community members, and participants who made this research possible. Thank you.
Thank you, Jay. So folks, I will encourage you to leave kind messages in the chat for Jay, as well as any questions you might have either in the chat or the Q&A box. A few have come in. So Jay, I would love to ask you a few of our attendees' questions. We'll get started with the first one that came in. So this question is someone asking about if participants shared with you how they first learned about MAID.
That's an interesting question. One of our eligibility requirements was that people had to already know a little bit about MAID, just so that we weren't introducing people to the concept of MAID and MAID for mental illness um, in the context of this research. Generally, people didn't talk a whole lot about how they learned about MAID. For a lot of our participants who are involved in disability advocacy or organizations, they had learned about it through their work there. Some folks just learned about it through social media and just general news. Um, and some people had learned about it through academic sources and venues, but it wasn't a huge topic that came up a lot for folks.
Thank you. So the second question here, I'm going to do a bit of my own spin on it. So whoever submitted the second one, if I got it wrong, please tell me that I got it wrong. But I'm wondering, I think the second question is about, are there ways or opportunities for the 2S LGBTQ plus community or people to be able to provide feedback to the government on the proposed MAID MI law?
Yeah, so in the last couple of years, the government has held some consultation with community, which has been criticized for being very inaccessible for people to participate in. They held some targeted consultation with Indigenous communities, which has also been critiqued for not being very inclusive or promoted very much. There has not yet been any targeted consultation within the queer communities or within any other specific communities, except for Indigenous communities. However, it is election season, as I'm sure that everybody knows. So if you are in touch with with the candidates in your area, always good to reach out to them, see what they're doing, um, make your concerns known. Um, it's an important time in the country right now, so it's always a good time to check in with the people in your riding and see what their thoughts are and what their plans are around MAID.
Mm. Thank you for that. There's a few questions that have come in that I'm going to combine around what are the criteria or how do people qualify for MAID for MI? So what types of illnesses or disorders qualify? So there's a question around, does gender dysphoria count as a mental illness, and what criteria are providers or doctors using in order to assess someone for MAID? And not to put you on the spot as an expert in this, Jay, but do any of those things come to mind, or would you refer to somebody to like a website or a resource to learn more about that?
Yeah, so it's kind of difficult because of the definitions that are used around
Mm,
mental illness, around how conditions are qualified to be irremediable, which is the terminology that's used in a lot of the MAID legislation. And what it comes down to is that it is often left to the discretion of the doctors or physicians who are doing the assessments. And there's also not a whole lot of oversight on how those decisions are being made, and
mm,
not a lot of consequences for decisions that may be made that kind of divert from model standards and the official guidelines. Um, but yeah, it's difficult. A lot of our participants, as I mentioned, had concerns about gender dysphoria and how that would look in being a qualifying illness or condition or disorder. But there's not been a lot of research done in that area,
mm,
and there hasn't been a lot of at least publicized cases of gender dysphoria and how that's navigated in terms of MAID.
mm. Thank you. So I'm going to take a question from the chat and I'll come back to the Q&A box in a second. Question from the chat is, I'm curious if there were any conversations or themes noted among participants who are 2S LGBTQIA plus international students.
Yeah, so we had a couple of international students who were participants, and one of the main things that came up there was in discussing, um, again, access to care, obviously a huge topic in this area and a big concern among participants. Our international students talking about access to care, and specifically in the area of suicidality. Um,
Mm,
Having concerns about disclosing suicidality to their providers, worrying about how that could impact immigration status, or again, worrying about carceral interventions, being
mm,
involuntarily hospitalized and things like that. And I think that was the main thing that came up among our international student participants.
mm. Thank you. So moving back to the Q&A box, someone said, I'm not sure how to ask this necessarily, but I'm wondering if there's been much work done in the area of MAID for mental illness that specifically rejects a suicide reduction approach.
I'm not entirely sure about the wording of this question, but I'll provide some information on the general topic. Um, Again, there's a lot of perspectives that come up around suicide and MAID for mental illness.
Mm,
I know I will put in the chat the name of a book, um, which I have not read yet because I am not in the headspace to read that at the moment. But I have heard good things about this book, and I know that it addresses a lot of the conversations around suicidality and made for mental illness. Um, Other than that, it continues to be a very complex field to navigate. I know there's research that is emerging and a lot of research that's underway, but yeah, again, a difficult thing to navigate, but hopefully something that more people will get to provide their perspectives on in the near future.
mm. Thank you. So the next Q&A, you have lots of questions, Jay. People are very interested in this subject. The question from the Q&A box is, have you run into any roadblocks disseminating the findings from this research?
Um, kind of. This was my thesis work, so my thesis is publicly available, and I'm very happy to have this report now publicly available through EGAL. Um, Currently working on getting a manuscript published through peer-reviewed academic journals. Have been running into a few roadblocks there of reviewers saying that it is too political. Reviewers, one of my reviewers accused my participants of lying, which I was not a huge fan of. And not participants, reviewers saying that it's too alarmist and that um, concerns around MAID are often pushed by the Catholic Church, which I thought was an interesting comment as a queer person doing very queer focused research. Um, but those have been some of the roadblocks getting it published in the peer-reviewed academic circles. But in any case, I'm very grateful for all of the opportunities from AGEL to get this research out into the public. I've also presented at a bunch of conferences, so doing my best to get the information out, at least into the community, if not into the academic sphere.
Mm, thank you for that. There's the next question's a little bit long. So I will read it because I think it does mirror some of the results you were sharing earlier, and it might allow you to elaborate on your presentation, which I know the results section you did in around 20 minutes, and I'm sure there's lots of results you could speak to. So if you bear with me, I'm going to read this question here. So it says, if accessible and affordable healthcare is a basic human right, how can that right truly exist when there's a 7-year wait list to see a doctor? That's not access, that's obstruction. And yet the government uses this loophole to claim they're providing care when in reality they're deliberately denying it to the most vulnerable. So I have to ask, how long before all public care is quietly pulled back and the only public healthcare option left is MAID? And when that happens, will they say our rights are being upheld just because death is easier to access than treatment?
Yeah, so this is obviously a very important question. And as Brittany was saying, it does mirror a lot of the concerns that came up in this research. Yeah, I think obviously Canada likes to um, highlight its universal health care, likes to brag that we're better than the United States in that way, but it is not hugely accessible for a lot of people, specifically people who, as I was saying earlier, live rurally or have complex or chronic conditions or who need culturally competent care. Um, it's very, Healthcare is very difficult to access. And again, when we're talking about mental illnesses specifically, a lot of mental health care is not publicly funded by the government. People are having to pay out of pocket or rely on insurance for a lot of that. So yeah, it is definitely something that the government uses to kind of deflect the criticisms that care isn't accessible to people. Another thing that they've been using to kind of deflect those criticisms is the Canada Disability Benefit, which the government talked a lot about in response to criticisms about Track 2 MAID for non-terminal illnesses, saying that the disability benefit is going to help lift people out of poverty and provide them with all of this support and financial resources that they didn't have before. Um, Obviously, for those who aren't familiar with it, the Canada Disability Benefit was postponed for a very long time, came out to only be a very meager amount of money that's not really going to lift anybody up out of poverty. Um, so generally, there are a lot of different things that the government uses to deflect concerns about access to care and about vulnerability and marginalization. And yeah, I don't, I guess there's not really an answer to that question. It's just there's a lot of issues and a lot of things that the government isn't doing to support people.
Mm. So we're nearing the end of the webinar, and you've been so gracious with your time. There's lots of questions that I am going to save and send you in an email, Jay. And for anyone who has more questions, I'm going to put our research email in the chat. You can keep sending them in. I'll pass them along to Jay. But I think I'll end it with one final question for you, Jay. Was there a finding that surprised you, or maybe pleasantly surprised you, or in the other way? Yeah.
Um, I'll go for pleasantly surprised so we don't end this on a sad and upsetting note.
Mm,
I think it was just, I don't know if it was surprise, but it was very heartening to hear so many people talk about um, their communities and talking about how even if they themselves experience suicidality, how they wanted to make sure that the people in their communities had the resources they needed and how they just wanted to take care of each other essentially.
mm,
And as I ended our presentation on, I think that's one thing that we can keep doing right now as the government is doing its own thing and not necessarily listening to our concerns. So I will end it by saying it's important to keep taking care of each other as much as you are able to in whatever ways that you are able to.
mhm. That's a great note to end this on. And just thank you again, Jay, for spending your morning with us. No matter, some of us it's our afternoon, but thank you for spending your time with us. If folks have further questions for Jay, feel free to email research@egal.ca. Check out Jay's report on our website. The link is in the chat. And yes, thank you again, Jay. And thanks for all of our attendees for attending and having such great questions. That was really amazing. I have a lot of gratitude to you all. So thanks very much.